Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. It's a pleasure to welcome Dr. Rishi Gupta, Associate Professor, Department of Ophthalmology and Visual Sciences at the Dalhousie University in Halifax, Nova Scotia. Dr. Gupta, you had an unusual case that really is fascinating within our field of pars plana vitrectomy for vitreomacular traction that had persistent loculated subfoveal subretinal fluid. You know, I think we're used to seeing that occasionally in cases, particularly when we would buckle, but it's a little less common in cases where we're doing vitreomacular surgery, and your case was relatively unique. So can you take me through a little bit of the approach to the patient?
Absolutely. So this was a 64-year-old with, as we said, visually significant vitreomacular traction. It was so significant he was patching the eye for the past 3 months. So he was quite symptomatic and very interested in moving forward with some sort of intervention. And we ended up doing a combined phaco-vitrectomy surgery. But very interestingly, intraoperatively and postoperatively, we had this subretinal fluid that was persistent for many, many months. And as you mentioned, we see this sometimes in different conditions such as retinal detachment, whether that's post-buccal repair. I actually have a patient who I'm following now post-pneumatic repair who has this persistent subretinal fluid. But this actually hasn't been reported in VMT post-vitrectomy surgery, to our knowledge. We have seen it reported in chemical vitreolysis and pneumatic vitreolysis for VMT. So I thought it was a really interesting case that made me reflect on a handful of different things like VMT and our options and how those have changed, over the past decade, thinking about vitrectomy itself and the different steps and how we can maybe try and optimize things to maximize patient safety, as well, thinking about multimodal imaging and OCT, and then thinking about this subretinal fluid and why in some cases, the fluid will persist, and why in some cases fluid is better tolerated than in other cases. So it was a neat case as far as, trying to make me reflect on different topics like that.
Well, let's go back even a step further, because you know that I'm a strong proponent of combined phaco-vitrectomy, but that at least within the US, that maybe has a limited deployment, whereas out of the US, very common. So you felt the patient had a visually significant cataract, but did you think you could do the procedure without the cataract being done, and you were doing this to optimize a single surgical recovery? Or did you feel that the cataract needed to be removed to allow you to do the surgery?
In this scenario, it was really to look at giving him a single procedure. I felt that I would be able to look through that lens during surgery, have a clear enough view to be able to do surgery. And so I always have a discussion with patients about the idea of a post-vitrectomy cataract, the possibility of that, and requiring then a second surgery and all the risks of a second surgery. And in the end, we decided to move forward with a combined procedure.
Yeah, I think in these cases where there's even a modicum of early cataract, if you're doing a vitrectomy in the macular region, those patients' cataracts progress significantly, fairly rapidly. And the patient goes from my vision is really good to my vision's worse than before we started. So I've had some disappointments with patients that have separated the two surgical procedures. Now, preoperatively, you looked at the patient. Did you do anything preoperatively before surgery, either pharmacologically or imaging, to give you a better handle on how to manage the patient?
That's a great question. I'm always very interested, of course, in looking at the OCT, and there are a couple of things that come to my mind. When I'm looking at that OCT, I'm curious, is this a very focal adhesion, or is this a broad sort of insertion? If somebody has a more focal adhesion, I'm thinking maybe this might, resolve on its own, more likely than if it's a much more broad adhesion. There's a nice study that we saw from Osley Retina with the first author, last name is TZU, where they looked at 230 eyes from various centers, and we saw that a third of patients, if you wait, a year and a half, actually had resolution. And so again, if I see more focal VMT, then I'm thinking, okay, maybe this might resolve on its own. I'm looking for epiretinal membrane. I'm looking for if there's significant cystoid changes or subretinal fluid, how much things are distorted. Is it really dragging and pulling in one direction or the other? And then sometimes you get these cases with quite extreme antero-postero pull, and the whole retina appears almost like there's a lot of schisis there, and large sort of cavities. Certainly those kinds of appearances make me nervous to move forward with an operation. So these are things that are in the back of my mind as I'm looking through the preoperative OCT.
We've also seen some experience with using a topical carbonic anhydrase inhibitor, hoping to alter retinal pigment epithelial pump function. Have you had any experience with that in your patients with VMT?
That's a great question. I generally have not leaned on that. I often will be much more keen to simply observe. I don't know if there's much of a downside of what you mentioned, but generally speaking, I am quite conservative with moving forward with vitrectomy. I'll really talk to patients, see where they're at, and a lot of them are okay, to give it some time. This gentleman had, as I mentioned, had such severe symptoms that he wasn't using the eye at all. He was patching it. And certainly I felt that moving forward with a vitrectomy in that setting after we had done a full informed consent made sense.
Yeah, I think a surgical decision was good. We have had some experience with the topical dorzolamide using that, and I found some benefit in some patients. It's a small percentage, but I also think that's beneficial when I have postoperative fluid in or under the retina. I'll consider that also. So you've got the patient, you're going to the OR. We don't need to talk about the phaco. I think that's straightforward. Talk me through the surgical approach to the VMT.
Absolutely. And I find this pretty interesting because my own approach has evolved over the years. I'm about 10 years into practice. And so I like to think of VMT surgery with two really important things to reflect on. So the first is actually elevating the hyaloid and separating that vitreomacular traction. And the second is if we're going to peel anything. So with the first one, again, we have significant pull on the fovea. And I think the whole approach during surgery, as I'm going in there, I'm thinking, how can I minimize adding in any more pull on that fovea? So when we're elevating the hyaloid now, I do like to try and watch the fovea as I'm elevating, do it under a high magnification. And sometimes you can go in with the cutter still on and high vacuum aspiration, and you can move around the macula, and sometimes it'll separate simply with that maneuver before I go to the nerve to try and elevate the hyaloid from the nerve and create the full PVD. Earlier in my career, I used to go straight to the nerve and I'd put it on full max vac, start aspirating, and I just pull straight up. Now I very much do it in as gentle a process as possible, and I like to try and after I've worked a little bit around the fovea, if I can elevate it there, then go to the nerve, elevate at the nerve, and as soon as I see that hyaloid pop off the nerve, I actually then go back on cutter. Usually I'm operating at 7,500 cut, and I like to try and sweep and progressively and very gently allow that hyaloid to start to elevate and progressively go towards the periphery. We know from some larger series, so there's a nice meta-analysis from 2013 with Timothy Jackson as the lead author, where 400 eyes are reviewed from multiple studies, and we did see about a 5% rate of retinal detachment. Right. And we know in these cases with vitreomacular traction, the hyaloid is adherent, and it can be very adherent even in the mid-periphery. So that was the scenario in this case. As I elevated the hyaloid, it was very stubborn once we came to the mid-periphery. And again, earlier in my career, I think I was a little bit more cavalier about just going back on vacuum and elevating and pushing and elevating, pushing. And I, would not infrequently in that sort of scenario get an iatrogenic break, where I'm much more cautious about that now, and I'm okay with, as I did in this case, leaving the hyaloid and not pushing it past that mid periphery, with the goal of trying not to create an iatrogenic break.
Rishi, do you routinely stain with triamcinolone, acetonide, or do you feel comfortable to elevate first without staining?
I typically will elevate without staining, and often what happens is, as soon as I ask for staining and our nurse goes and gets it, and then they start to draw it up, I say, I don't need it anymore. But certainly there are times when it's very beneficial, and I'm being a little facetious, but, placing it into the eye. And sometimes that really shows you, especially along the nerve, if you're having trouble, oh, there's, a little edge here or a pocket here where I can go in, and that's what's going to allow me to lift things up.
Yeah, I think you're absolutely right. So if you are approaching the case, there's nothing wrong with staining. I think once you're more comfortable, you stain very little. But if you're having a hard time, stain. And if you're early in your surgical career, stain. Now you've got the hyaloid off. You didn't get a peripheral break. Good for you. Now, what are you going to do with the residual macula in this case?
So very interestingly, during this case, as I elevated the hyaloid, immediately I saw what appeared to me to be subretinal fluid, and what was later confirmed with OCT testing. So this happened intraoperatively, and we've all, I think, had those cases where either the ILM, the ERM, or even the hyaloid is very adherent. And we can imagine a scenario where the neurosensory retina might elevate somewhat. So here I was, doing the case, saw what appeared to be subretinal fluid form. There was epiretinal membrane that needed to be peeled. And both the epiretinal membrane and whether or not you're going to peel ILM, I typically do that. Again, going back to that 2013 series from Timothy Jackson as first author, we know that macular hole is a complication that we can get from these surgeries, which was seen in about 1% of those cases. So I do like to, if I'm there, peel the ILM. Both the ILM and the ERM were extremely adherent, but I was successful in peeling those. And again, another thing that I've changed a little bit in my practice over the years is I would get these cases here and there, as we all do, of extremely adherent ERM or ILM. And it impressed upon me probably the importance of trying to peel towards the fovea. As you're going around that circle, constantly trying to peel towards the fovea rather than peeling across it and then continuing to pull in one direction, which again will put more traction on that fovea. So again, going back to it, as I go into these cases, I'm thinking, how can I minimize my chances of getting a retinal break, and how can I minimize the traction on the foveal center?
So you saw the fluid, you didn't see a break, you've managed the membrane. What are you thinking about in terms of tamponade at that point?
My thought is going towards that there must be a little micro break that I may have created as a possibility, or maybe this was just mechanical traction that's pulled it off. But in the event that I have this micro break, then immediately I'm thinking that I want to put in some sort of gas. I think air would be fine. I leaned on SF6, and I asked the patient actually to position face down for several days as well, with the hope and the expectation that this fluid would be gone very soon.
And so it must have been disappointing for that first OCT after you've operated with release of the hyaloid, release of the membrane, and a tamponade and persistent subretinal fluid. So how did you then discuss that with the patient, and what did you decide to do?
Absolutely. So a lot of these case reports, and I'll congratulate you on this series. I mean, I really enjoy watching these videos, and I think JVRD has done a wonderful job allowing us a forum to bring about, a lot of these case reports. And most of these case reports are going to bring opportunities for very critical, crucial, important conversation and communication with the patient that can, be challenging for all of us. the patient's disappointed, you're disappointed, and so how do you together, move forward in an honest fashion and maintaining that relationship? It's challenging sometimes. This was a very understanding patient. We had done a very good consent. So when I discussed with him where we were at and what my hopes were, I had an expectation that the fluid would go away soon. I said, but time will tell. And so we observed, we watched, and month after month after month, unfortunately, we had this persistent fluid, and the vision was actually worse at this stage from a Snellen acuity perspective. So from every standpoint, we were struggling, unfortunately. And so luckily, again, he was a very understanding patient and a patient. And in fact, I saw him just a few weeks ago, and the fluid finally did resorb. An update to the paper, and this is 20 months later that the fluid actually resorbed. With the vision then, for some time it dropped down to about, you'd say 2100, 2200, but it actually picked up back again and ended up at about 2070, which was where he started preoperatively. So happily we came back to the same acuity. But he did say actually his metamorphopsia, thankfully, was significantly better, so he was no longer patching the eye. So we did have a modest improvement at the end of the day, although it took 20 months to get there. So we had to be very patient.
And remember, too, that vision can even continue to improve in these cases. And since you had an anatomic compromise to the vision, now that that's resolved, you may actually see recovery of vision. So I would keep my fingers crossed that you're gonna do well.
That's a great point.
So Dr. Gupta, thank you so much for joining us. Great discussion. I think when you listen to this, there are so many pearls that you have incorporated into your surgical approach that I think are really relevant. And I think you're right. The conversations around this become very fascinating. People have very strong feelings about when to manage something and how to manage. And so I think you did a superb job in approaching this with the best, approaches, evidence-based available to us, and then a measure of patience that I've got to say I don't have. So good for you, 20 months waiting and resolved. So thank you very much. Really a pleasure to have you with us.
Thank you so much for having me. And I just wanted to give a shout out to Darcy Wilson and Ashlyn Pinto, who are the co-authors on this paper. Thank you for having me.
Absolutely. Thank you so much. Really a pleasure. Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts, Google Podcasts, and Spotify. Visit www.asrs.org/JVRD Forum on the ASRS website to learn more. See you soon.